topic is on diagnostic evaluation of angle closure glaucoma in the present scenario, which will be presented by Dr. Ronnie George. Dr. Ronnie George is also quite well known to us in Kerala, as he is a regular invited faculty at many of our conferences. So that's it. He is presently the Director, Glaucoma Services at Shankar Nethralaya. He is a professor at the Elite School of Optometry. He is the Director of Research, Medical and Vision Research Foundation, Chennai.
Thank you, and once again, thank KSOS for the kind invitation. So I'll be talking about the other stool, not the three-legged one, the other stool, which is angle closure glaucoma. And the reason why this question comes up again and again is because there are lots of technology now which assesses the angle. And does this in any way help the way that we have started looking differently at angle closure glaucoma? When we look at angle closure glaucoma, the one thing that is, the other two legs of the stool stay the same, the IOP is the same, your optic disc and your functional tests are the same. The only different thing is the angle, and that's what I'm going to talk to you about now. So the anterior segment OCT is now with us for about 20 years, and we still wonder how we're going to use it in angle closure. And the primary reason for this is because it hugely overcalls angle closure. A huge bunch of normal patients also come up with having angle closure on an ASOCT. What we use it for now is this lens vault. So if you see a large lens vault like this, that can help you to decide which eyes will benefit from a lens extraction in addition to any other thing that you want to do for angle closure. The problem is that we don't really have well-defined cutoffs for this, but this is an additional piece of information that you can use. In fact, this paper that looked at angle closure versus normals had an almost 600 micron difference in lens vault between the two groups. So this is what I was talking to you in terms of it overcalling angle closure. It correctly identified almost all patients who had narrow angles on gonioscopy, but it diagnosed 50% of those who had open angles on gonioscopy as narrow, and which is why we don't use it routinely in the clinic. What happens if you improve technology, if you improve the resolution of the image? So what you do over here is angle-to-angle scan with a high-definition OCT. And with the high-definition OCT, you can see that you get much better images. Does this help? And when you look at both the area under curves, very similar. So improving technology also did not seem to really help very much with the diagnostic ability of these two tests. What about agreement between the tests? If you look at the agreement between gonioscopy and OCT, we already spoke about it. But if you look at the agreement between Visante and Cirrus, you still don't get complete agreement. And that's because these are all based on individual slices that you're taking. And angle closure based on a single slice, if you have a little iris bump there, might look narrow in one angle, but might look open in another slice. So that is the reason for this difference. What about image analysis? Can you use image analysis to help you do this? And what you can do is the segmentation and quantification of these images. And with the segmentation and quantification of the images, you do find that they use basically artificial intelligence to do it. You find much better area under the curves. So with these area under the curves, maybe once you bring AI also into the picture, you may actually land up with something a little better. The next OCT that you have is basically the swept source. So with the swept source OCT, you actually now scan the entire angle. You are not taking slices. And this is how we do gonioscopy, and this should actually do better than you do with just standard slices. So when you look at the open versus angle closure here, you can see that most points on this graph are open. And you see this sort of a graphic there which shows you that these are the places which are a little dodgy. And this is a closed angle. And here you're seeing that the entire angle is looking close. So this quantifies the degree of closure. And this is actually something that's fairly useful. But it has some challenges which I'll come to a little later. Surprisingly, even this doesn't do exceptionally well versus gonioscopy. It does about the same as what the ASOCT does. Here again, all the ASOCTs, this is the issue. Your information you get is from the slice from which it was taken. You cannot assess PAS or pigment, etc. The next thing that people came out with was the iCam. The iCam is basically a modification of the RETCam to take pictures of the angle. And it's very nice in congenital glaucoma when you want to document what the angle looks like. In terms of angle closure, because you still have light issues, it can be a problem. When they looked at iCam and ASOCT, they actually found that it was marginally better than the ASOCT in detecting angle closure. That's mostly because the specificity was better, not so much because the sensitivity was better. So this, now we are all moving to the era of angle surgeries. And with angle surgeries, everybody is worried about what is actually going on in the trabecular meshwork, what's happening in the outflow channels. So you have this experimental device which managed to image the trab meshwork to a theoretical resolution of 5 microns. And this is what you're seeing. So these are actually porcine eye images, and you can see fairly reasonable resolution achieved in porcine eyes. It's still a way away from the clinic, but we may be reaching there sometime soon. So the innovations in angle closure, they've helped us to better understand disease, but they don't really have adequate diagnostic accuracy for us to use them for detecting angle closure glaucoma. Improvements in circumferential scanning will provide help. So to summarize, right now, with gonio photographs, we don't know about occludability, and light is an issue. With ASOCT, we don't know about synechiae, and that becomes a problem. And with the swept source ASOCT, we don't know about pigment. So currently, even today, gonioscopy, because you can still get information of occludability, indentation, and pigment, is still the gold standard for how we manage angle closure. Thank you once again.
Thank you, Dr. Ronnie. I request Dr. Jyoti to please give a memento to Dr. Ronnie.